The first thing the military guys will come in and say is, well, I'm just here for military trauma. If you're at this level of care, you're not here for that. We will address that, but that will be something we address later after we've got the foundational pieces. And so we have to explain that to them when they come in, because they're like, no, I'm here for combat trauma or this type of trauma. If outpatient isn't working in the military unit, it's because there's something else.
Welcome to Beyond Theory, a podcast powered by Meadows Behavioral Healthcare that brings you in-depth conversations with firsthand insights from the front lines of mental health and addiction recovery. I'm Dominic Lawson. Many times when people seek treatment for trauma, they are addressing something that happened to them recently. However, there's often something that lies underneath that also needs to be addressed. Chief Clinical Director of Meadows Behavioral Healthcare, Scott Davis, makes the case that true recovery can only be reached when everything is addressed, not just the part a person is comfortable with. But how do you get a person to open up to meet them where they are? Let's get out of the abstract and see how this applies in the real world. It's time to go beyond theory.
So my name is Scott Davis. I am the Chief Clinical Officer of Meadows Behavioral Health, and I'm glad to be here.
I'm so glad to have you. Welcome to the Beyond Theory podcast, Scott.
Thank you.
Just kind of share your background, if you would.
Well, originally I'm from Texas, and so probably around my 30s, I decided to go to, I had been working with protective services in Texas, decided to go to graduate school, went to graduate school at University of North Texas, got my master's in education with a specificity in community counseling.
Mm-hmm.
From there, I was doing an internship at a place called Sante Center for Healing, and they hired me out of my internship, and I worked there for approximately 2.5 years. Then decided to go into private practice, did private practice for about a year, got really bored with private practice because I may have some intensity issues. And then went to a place called Cal Farley's Boys Ranch. 26 homes, about 500 kids. And I was one of the counselors out there, specializing in addiction and trauma. And so there when we're looking at, how things kind of developed out there, is that they sent me to quite a few trainings. I was already certified in challenge courses. I did some training with neurofeedback. I was an EMDR practitioner, so I advanced in that and did work around dissociation and trauma, childhood trauma, things like that. So that really set me up, and then decided to come back to the Dallas area after being out there for almost 3 years. And went to work back for Sante, and from there was the case manager, a program director, where I did program directing for the eating disorder program that they had on campus. And then after that, I was the clinical director for a place called Inner Health.
Okay.
And was there for about 9 months. Would you like to hear the story about how I got to the Meadows?
I would. Okay. I actually want to ask some follow-up questions about some other
follow-up
stuff.
questions.
Yeah, I wanted to ask you about your work with children, because we're seeing a lot of childhood trauma these days,
Right.
or we're talking about it. Kind of tell me about that work, if you would.
Well, a lot of the work that we were doing was actually with a well-known child psychiatrist, Dr. Bruce Perry.
Mm-hmm.
And he works a lot with one of our other senior fellows, Dr. Van de Kolk. He was doing work with Cal Farley's Boys Ranch. And so we were actually seeing a lot, because we had been seeing a lot of kids that were coming in with neurological issues and neurological delays. So we would see issues with their gait, with the way they walk, fine motor skills. They just weren't having those what we would consider appropriate or
Right.
normal or normative. And with that, we started looking at what the reasoning is. And so it was then we started looking at trauma and what these children had gone through. And so severe neglect, abuse, things like that will tend to delay the brain's ability to hit its normal paths or its normal age appropriateness. And so these kids were coming in and they were, 10, 11 years old, and they're acting like they're 5 or 6 or sometimes 2 or 3. And so Dr. Perry was able to give us words and let us know exactly what was happening. And we were able to, at that point, actually heal some of that damage that had been done. And so we were taking kids that were fairly damaged in their ability to kind of work with the rest of the world. They were labeled as ADD, conduct disorder, all those things that you get when you're a child, and weren't doing well in school. And we were able to kind of turn that around. And so we had a lot of techniques. We used equine therapy. We used neurofeedback. We did a lot towards just establishing activities that were pattern repetitive, that actually were shown to heal the brain.
Quick follow-up to that. But I imagine that you're working with the parents of some of these children and having those conversations with them. What was that like? Or what is that like? Yeah.
Anytime you're dealing with a parent, especially, and even now when we're dealing with parents that are of adults, it's always hard to look at our parenting role and know that we've done something wrong. And, some of the parents were receptive, because they had seen, because of the way they'd been living or the way that they had done something, to kind of harm the child. They were all willing to look at that. And then there was also your parents that were more resistant, because they were still in that lifestyle. They were still doing those things that caused them to have issue, and also attributed to the child's being abused and neglected. So it really just depends on the parent. How much are they willing? And of course, at one point, I was actually they would drive me into Amarillo, and I would actually counsel with parents. I would actually do counseling with parents, and that was part of my my job role out there, because the parents were asking the facility, "I've seen this change in my child. Can you help me with be a better parent and go through some counseling?" And so I was actually doing some adult counseling at that point as well. One time a week, I would go in to Amarillo and work with the parents.
And that led to your journey here to the Meadows. Kind of talk about that.
Well, I was working at Sante, and I at some point I decided that I was going to be a clinical director, or wanted to be a clinical director. It's like one of those things. I'd been a therapist for about 9 years and didn't really want to be anything else until, there's a point where people start going, "You should be the clinical director. You should be the clinical director." And finally you just start going, maybe I should be the clinical director. Applied for a position with another facility. And with that, I had met a recruiter, and she was asking me, would I be willing to move here? Would I be willing to move there? And I said, "Ma'am," I said, "you don't understand." I said, "I'm from Texas." I said, "Texans don't leave Texas." I said, "Otherwise, we're not Texans anymore." And she kind of laughed, and I said, "No, I'm actually serious." I was like, "Texans don't leave Texas." And she's like, "Well, is there any place you would go?" And I said, "Well, there's this place in Arizona called the Meadows." I said, "I've basically read everything that they've put out as far as their senior fellows." I said, "If they ever call, I would love to go there." So about 6 months later, she calls me and says, "Well, how do you feel about Phoenix?" And I'm like, "Oh, I hate Phoenix. It's hot." She goes, I'm like, "It's already hot in Texas. Why would I want to go anywhere place hotter?" And she says, "Well, what about if it was the Meadows?" And I'm like, "Okay." I'm like, "Tell me more." And she's like, "Well, I've talked to them about you, and they seem they would we want you to apply." And I'm like, "Okay." So that was basically how all that began. It's like, you put that out to the universe, and suddenly the universe talks back to you. So I went through quite a few interviews and wound up as the clinical director at the Meadows.
Right, and now the universe has spoken again, and now you're the chief clinical officer at the Meadows?
That was a little bit surprising. I know that it's a matter of timing thing, and yes. So now I'm the chief clinical officer. So I'm very excited about that.
And what does that new role entail for you? Like, what is talk about that a little bit.
Well, it's a role that the Meadows has not actually had before. So it was, so there's a little bit of ambiguity in that of not knowing what this is going to be. Some of that role, in talking with what the need is out there is really, we have some really great senior fellows and we have great programs, and the programs have a certain way that they are working, and they have curriculums that they go by. And what I've noticed for most of our facilities, and this is common for really all facilities, is that they don't always have a lot of cohesiveness between what their intentions are, what their curriculum is, and how to help the patients. And so hopefully there is some place for me to help with the intentionality of that, and to bring more cohesiveness to those programs, and really to meet the needs that they have, because we have so many talented people, and with the timing of everything, you don't always have time to accomplish all the things that you would like to, as far as making sure that things work the way they're supposed to. And so anytime I can help with implementation or research, or basically with those facilities, that's something I'm going to do. And then the other is just to make sure that our Meadows model is kept central throughout our programs. And when we're talking about the Meadows model, it's about making sure that our senior fellows, the work that they do is not lost, does not get sidelined out there, but that remains front and really is a guiding force with all of our programs. Anytime that I can work with our staff on mentorship or supervision, that's something that I'm going to be excited about as well.
You talked earlier about cohesiveness, and now you're talking about the Meadows model. And that's one of the things I've always loved about the Meadows, as far as the Meadows model being across board, whether it be at one of our facilities, whether it be virtual IOP, that Meadows model is always just a standard that everybody seems to want to reach. Just kind of talk about a little bit in detail about the Meadows model, or at the very least, your commentary on it.
Well, the Meadows model, most of the time when we're talking about the Meadows model, we're talking about Pia Melody's model.
Of course.
And of course, I love Pia's model because Pia started at the Meadows as a nurse. She was the director of nursing. And what she did is she just kind of noticed that most of the people that they were treating had addictions, but they also seemed to have some certain commonalities. And being a nurse, she said she started putting it into symptoms. They all seem to have these symptoms, and they all seem to, and then she was connecting that with, they all seem to have these trauma in common. And so there was some commonalities there, and she started, just like any good nurse, diagnosing some issue, was diagnosing and then looking at what the issue, how they could fix it. And so when you look at the model of immaturity, that's basically, and we look at that as the Meadows foundational model, is that's what she was talking about: symptoms and ways to fix them. And also, the most important is to give the patients a common vocabulary, so that they can start identifying their own issues and kind of say, well, I'm codependent, but I seem to have these issues with intimacy, and that comes from my childhood, and this is what happened. And so with that, you have a certain amount of speak, but the Meadows model goes really further than that, because when you're looking at the Meadows model, depending on what campus you're talking about, the Meadows model is not going to be just the foundational work of Pia. It's also going to be, if we're looking at Gentle Path, it's the foundational work of Patrick Carnes and the work that he did and how that builds with the model. And then if you're looking at one of our other, Claudia Black Center, she and Pia worked very well together. And when you look at Meadows Maine, half the program is, when you're looking at the family program, that a lot of that is Claudia Black's stuff that she's written. So when the Claudia Black Center came around, it's like, well, it's not necessarily Pia's program, it's Claudia's program. And so she's writing the curriculum for that. And so when we look at that Meadows model, it's like, it's not going to be all of Pio's work, but it's going to be a little bit of Pio work and a lot of Claudia's work and then a little bit of Van de Kolk's work. And that's the way the Meadows model is now is it's not just Pia's work, but it is Van de Kolk's work. It's Patrick Karn's work. It's Stephanie Karn's work. It's Dr. Schwartz's work. So we're looking at how we can integrate those and actually build all that together and be very intentional about what we're doing.
Absolutely.
Because they all in some ways fit together. And that is kind of the difficulty when we're looking at all these different models of all of our senior fellows is how do they work together? And so we've been able to, at Meadows Maine, really kind of put those together. And then all the other facilities are also putting those together as well to make sure that we're all well informed, we're all doing good trauma work, and we're really staying true to some of the precepts that the senior fellows have kind of set down for us.
I want to ask you this because I know you've worked with the military population as well, from PTSD, SUD, things of that nature. Kind of talk about that work a little bit.
Well, most of my work, it started when I was with Sante Center for Healing because we were getting military folks in. And, and always when we're looking at military, especially when they're bringing people into a center that is not military, that usually means that somewhere along the way, the outpatient programs that they're using aren't working, and that's not necessarily because they don't have good programs. Because the military has excellent programs to help veterans and help their military folks. The issue comes in is that sometimes, just like we find in our current system of healthcare or mental health care, is that you need a little something more. And so they started realizing that some of their people needed something more because it wasn't just about the combat. It wasn't just about what they had experienced in the military. It was some of these other things that were holding them back. And, oftentimes what we'll see with our current folks from the military and the folks that I worked with in the beginning from Sante is that they would come to us because the military had they joined the military to have another family, except this family was supposed to fill the needs that the family didn't meet in the original family. The problem is that the military is an entity. It's not a family and you start to look at those relationships and you can build that family. But oftentimes the family that we build is the one that we came from. We have this propensity to want to resolve those issues. And so we tend to bring people to us and identify people, even if they aren't our mother, our father, our sister, our brothers, but we tend to identify them that way. And when we start identifying people that way, we tend to fall back into those old habits that tend to get us into bad places. And so most of the people that were coming to us and the people that currently are coming to us are in some type of bad place with the military, or they are going to lose their career, or they're using or something like that. And most of the time our approach is to first address those underlying issues of the trauma that they had growing up in their family system, and then we start working on the adulthood trauma. So a lot of times, the first thing the military guys will come in and say is, well, I'm just here for military trauma. If you're at this level of care, you're not here for that.
Right.
We will address that, but that will be something we address later after we've got the foundational pieces. And so we have to explain that to them when they come in, because they're like, no, I'm here for combat trauma or this type of trauma. I'm like, like I said, if outpatient isn't working in the military units, it's because there's something else. And so when we're looking at the treatment, as far as where I started with Sante and the current work that we're doing with the Meadows, it's the something else that we're going to be addressing.
Scott, let me ask you this, because I know the military population is maybe a little different from other populations that you treat, and you talk about that childhood trauma, familial trauma, not just combat trauma. How do you build that rapport with the military population in order to reach that part of treatment, if that makes sense?
Well, that can be very difficult because they're so used to dealing with military folks that and the military system that when they come to our system, they struggle a little bit. the first thing that seems to make the transition a little bit easier is our food tends to be a little bit better. And you think, and it seems like a very trivial thing, but at the same time, it's like, I'm like, but military does have this idea of running on its stomach. So the first thing is, we get you in there and we get you a good meal, and they're like, oh, this is really good. And then they also, the other part is that our peer community, is very inclusive. And specifically with military, it's like we have a good number of military folks there. So they're there and they kind of set the tone as well of like, no, you can trust these people. They're going to take care of you. And so we rely on that peer community. And then it really is, we actually have hired, we have therapists that are actually ex-military, and that has been beneficial for us because they understand the culture and they understand what the military folks are dealing with, and so they can kind of speak that language to them. And so that has been extremely helpful. And then really it's just meeting people where they are. I mean, most of our therapists, because of their bent for being person-centered, they really want to be able to make that connection. And so, we have groups, but our groups are assigned by issue. So whatever issues they come in, they're going to get assigned to a group that has similar issues to they do. So that helps them kind of settle in, and that helps them kind of start to trust. We also look at ways that we can actually make those connections by the questions that we ask. And 2 years ago, we went in and threw out all the questions that we asked in the beginning because we weren't getting the connections that we wanted to with our military folks and with our regular patients, and revamped our introductory questions that we ask to actually help with that connection. And what we've seen is with that, our AMA rates have actually gone down by 1.5 points because of that, because better connections are being made. And, our surveys have actually gone up because of that, of saying that they feel more connected, with the groups and with people in general.
One of the things I love that you said, Scott, two things is that, you talked about meeting people where they are and making that connection. And I think we have a lot of therapists or aspiring therapists and clinicians who probably need to hear that. You know what I mean? I think that was very important to say. I was reading an article not too long ago about emotional freedom techniques, and I was in a meeting with you as well, and you kind of talked about that a little bit. Kind of share with us a little bit about that if you don't mind.
Well, without going into, because I don't want to.
Of course, right.
I'm like, I don't want to try and explain my way around emotional freedom. The Meadows is, when we talk about the Meadows Model, or we talk about how we deal with all those type of issues, and emotional freedom techniques actually. Prior to them going into survivors, actually, we sit down with them in a class and we teach them how to help themselves and how to work with how to be able to self-regulate. And so it is part of our regulation system that we look at, and because what we found is that you can have the best curriculum out there, you can have the thought leaders in the process and doing all the best work as far as your curriculum and lectures and all that goes. It is great. But if nobody hears it, it doesn't matter. And so one of those is that we use as emotion freedom techniques. We also use our CES, or cranial electrostimulators. We use neurofeedback. We use Tai Chi. We do yoga. We do acupuncture and meditation. And all these modalities are part of what our senior fellows have kind of said these are really good techniques to use, but also the intentionality behind that is kind of reduce that arousal in the brain so that the brain can be open to taking in more things. And what we know about trauma in general is that trauma is experienced in a very high arousal part of the brain. And so if you can lower that arousal in the brain can actually make that trauma into working memory. Where it isn't someplace that the patient gets stuck, but it's a place where the patient can have feelings about and emotions about, but they can move through that and move past it and be able to, put it into working memory. And that's really what we're trying to do with trauma. Cause you're not, people think that you can kind of take trauma away. You can use EMDR, or you can use somatic experiencing to take that trauma away. But those techniques which we also have at the Meadows, don't actually take the trauma away. What it does is it puts it into a different framework for the brain to process it. Because really the brain really just wants to make sure things don't happen again, make sure that bad thing doesn't happen again. So it keeps on reliving it. And to get back to the original question, which was talking about emotional freedom techniques, that is one of the ways that one of the techniques that we use a lot to really help the patient and to kind of give them a tool that they can use. And as therapists, we use that to be able to reduce that arousal in the brain. So a lot of our staff actually has that training and uses it on a daily basis, whether it's in a group setting, whether it's in an individual setting, or whether it's getting them ready for survivors, because survivor tends to be more of what we call exposure, where we talk about exposure therapy. So it's very regimented, but they're going to need regulation through that as well. So we want to regulate them through that as well.
Of course. As we wrap up here on the Beyond Theory podcast, I want to say thank you so much for coming.
Oh, you're welcome. This was great.
Awesome.
Like I told you before, I've been wanting to get on here and talk with you.
Well, there you go. You be willing to come back?
Of course.
Okay. Awesome.
Of course.
I wanted to ask you this because, as you know, we're in the midst of a new school year for a lot of places across the country. Your work with working with childhood trauma and things of that nature. We know a lot of school children are kind of experiencing some of those traumas. I guess as a parent, what are some things that we should look out for as the school year kind of progresses and everything that's going on? Kind of talk about that a little bit.
Well, I know that as we've seen with the COVID and with the uncertainty, that a lot of kids are really reactive to that. And even in my daughter's actually fixing to go to the ASU for her first year. And to hear her friends talk, which are teenagers, and they've got their whole lives ahead of us, and their level of worry. And I'm like, so if they're worried, I have no idea. I have no doubt. And of course, we've also been hearing of children being worried. And so I think for the best thing as a parent is just to be open and talk about it, and we might have to also look at how we're regulating that news, because they're hearing the news, but it's not being filtered through the parent. So the parent, if there's news or there's things that are happening and there's information coming, we as parents have to be very vocal about what they're actually seeing and how that the world may be going through this, but at the same time, you're safe here. We're safe at home. We have safety here. And we also need to look at what the boundaries are. When we're looking at boundaries, oftentimes boundaries create safety. So if I have a well-boundaried home, then, and meaning that everyone's safe, everyone's going to be taken care of, physical needs met, those are all looking at all boundaries. If there's boundaries that are met at home, and those boundaries need to be met at home, then the child is going to feel safe no matter where they go. And so if that home situation is safe, then they're able to take in what I call novelty. And novelty is like the unusual things that happen to us on a daily basis. If we have a good basis home life, then we're more likely to be able to take into those that kind of craziness that kind of we encounter on the outside world. So really it's creating that nice home space. And the way that we do that is making sure that not only making sure that they're fed and clothed and all those good things, but also that we're listening, that we're communicating, and that we're also setting boundaries with our children to make them, because boundaries really do equal safety.
Scott Davis is the Chief Clinical Director at Meadows Behavioral Healthcare. He has experience treating patients and military personnel who have substance use disorders, sex addiction, eating disorders, and trauma. In addition, he has training in such modalities as neurofeedback, brain mapping, EMDR, and more. For more information on Meadows Behavioral Healthcare, go to meadowsbh.com. Beyond Theory is produced and hosted by me, Dominic Lawson. You can discover more, including videos of some of our conversations, at beyondtheory.com. Finally, thank you for listening, and I hope you join us next time for another episode of Beyond Theory.